Neil, I know you've also been very involved with the AUA about an initiative on a broader scope of how urologists need to be involved in men's health. So how does this concept of ADT, of an ADT clinic, advanced prostate cancer clinic, bone clinic, whatever, how do you view that as part of this global men's health initiative amongst urologists?
Sure. What we've done is we've put together this AUA men's health checklist, and the part that I helped contribute to was the aspect of prostate cancer and urologic oncologic issues. And what we've talked about and we've all come to recognize is the multiple different toxicities and side effects associated with androgen deprivation therapy, and how we can be better stewards of our patients' care, not just with bone demineralization, but with quasi-metabolic syndrome, and how we can do much better in terms of having these types of specialty clinics. I think it is best coined an ADT clinic, and by having the appropriate person there to give the counseling, whether it's vitamin D calcium supplementation, checking baseline vitamin D and calcium, educational materials on avoidance of the sedentary life, of active, regular core strengthening exercises, even just changing footwear and loose garments on the floor to avoid fracture. But you know, it's true what David said, is there's been a big educational effort for our colleagues to understand these fractures are real, cognitive impairment is real. So I think we've been more judicious in understanding how to use ADT, but also, if we're going to use it, how to safeguard our patients. And I think, as we've all said, it's not just the institution of ADT, but if we can monitor those patients who are living longer and recognize when they develop castrate-resistant prostate cancer, going from being androgen sensitive to castration-resistant, be it with radiologic evidence of disease or not, now we suddenly have newer therapies to be thinking about. You know, one of the great things was the development of a subcutaneous therapeutic like denosumab. We were using zoledronic acid early on. I remember, David, you and I were giving presentations on this back in the mid-2000s, and most of the urologic community was just reluctant to get involved in an intravenous therapy back then. I think the advent of a subcutaneous administration of denosumab and also all the education that's occurred has really shifted the way our colleagues are looking at this and recognizing that it's very simple to implement this and put these clinics together. So the male health checklist that the AUA is now going to, through the Office of Education, really aggressively promote, I think makes for better care, makes us all better physicians.
So Mark, you've got a big group, you're thinking about incorporating this, and you also have this unique challenge of having peripheral sites, and so given the information that you've got right now, so how do you foresee yourself and your group moving forward? And
well, I think what Paul said is very important, and I'm going to take it back and I'm going to help direct our group towards the ADT clinic. I think it's right. Metabolic syndrome, many of the other things that go along with ADT is a lot bigger issue than just bone density, and I think that that's an excellent message, and I'm going to take it back. I'm going to also, we're now converted to EHR, and I think it might be nice to come up with some parameters in our EHR where we can follow and maybe continue to collect information and data so that we can be a little bit more objective in how we're evaluating these people and what difference we're making with some of the things that we do, whether it's bone stabilizing agents, calcium, vitamin D, exercise, and all those kind of things. Maybe we can come up with some measures to really assess that. And I know we're going to talk about that in a little while, about information. I mean, I think this is a good opportunity to get better information and incorporate it so we can look at it and see what difference we make.